of this because the patient is at risk for airway compromise.
Okay.
Airway needs to be protected.
Anything else you would do?
Um, I would also like to image the chest because I don't know the inferior extent of the lesion.
Okay, that's our time. Honestly, I don't have much to add. You did really, really well. Are you a consultant radiologist already, or
Yeah, I am
yeah,
working as a radiologist.
you are? Yeah, I can tell. You're ready. I don't know what else to tell you. Nothing really to add. You did really, really good in those cases. Um, you could teach me some stuff, to be fair. So yeah, really, really good job on all of them. I'll just go over them quickly for other people, but
Oh,
nothing to add in your technique. You're clearly
thank you.
knowledgeable. You were safe. You did all the right things. Yeah. Just do that in the exam, and you'll be totally fine.
Thank you.
Yeah. So in this case, yeah, like you said, there's complete destruction here. It's basically it was yeah a sinonasal a squamous cell carcinoma in this case, complete destruction, also involved in the brain, vasogenic edema, neurosurgeons, ENT, MR, and yeah, let them decide what to do. A little bit of possible blood here is the only thing maybe to add, but um, um, so chicken bone in the cake fries in the abscess case. We'll get to the abscess case after. So yeah, maybe a little bit of blood here, but otherwise beautiful, beautifully done. Also, this case, great case of satisfaction of search. That didn't stop you. You got both findings straight away, RCC, appendicitis, looked for complications, and I try to even make it hard for you. Asked if you biopsy it, you're completely right. We don't biopsy RCCs. They go straight to surgery, CT chest, just like you said. Nothing to add there. And yeah, first do the appendicitis, worry about the RCC later, exactly like you said. This case, very tricky as well, but again, you handled it really well. You've got this epidural collection here and another one here. This one's a bit tricky, but this one's the main one looking on the axials again. It's compressing the nerve roots, pushing them forward, and yeah, this is like you said, an emergency for the cord, for the nerve root compressions, the cardiac compression. So neurosurgeons again, and yeah, this was epidural infection, just like you said. Initially, I think you were going along the route of I think a vascular lesion, but then once you looked at the stir, you realize it's a collection. So really, really good job. You also noticed the paravertebral tissue changes, and also, yeah, there's some involved in the paraspinal muscles. I think you said psoas abscess. There's no actual psoas abscess here, but it doesn't matter. You did really, really well. And last case, because you did that one so fast, I had to give you something else, but again, beautifully done. You've got this, yeah, collection on the left side, and then retropharyngeal space, paravertebral, gas mixed all the way down. Nasty looking, and yeah, it doesn't limit the chest completely, but already I'm very concerned that there's mediastinitis because you've got thickening of his right paratracheal stripe. Like you said, the visceral space involved, it's all over the place, it looks nasty. And yeah, someone was saying, is there a fish bone or something stuck? I don't remember one being in this case, but I will have a quick peek, see if there's anything dense. No, nothing obvious on there. And someone said, what's with the mouth floor? Let's see, what's with it? It's just part of the tongue and part of the infection. There is some collection spreading in the submandibular space too, so it's all probably just reactive. It's a nasty infection. So the mouth floor is part of that's the tongue, and part of it's just collection spreading through the submandibular space. Is it Ludwig's? Not really. Ludwig's, you'd expect a little bit more, the floor of the mouth extending here. So no, not really Ludwig's. More in keeping with peritonsil abscess and retropharyngeal collection. Cool. Nothing to add. Keep it up.
Thank you.
So yeah, I guess yeah, you're in a fantastic place for the exam. All right, next, Dr. O, you're back. Let's try. Let's try again.
Thanks for bearing with me.
No, don't worry.
I'm not sure I want to go anymore after that one. It's so good. Okay.
Yeah, it was oh, I need to get all of these. Let me do it like this. and then like this, and then like. All right, so if you share your screen and
So this works now.
I will get the timer ready.
Can you see that now?
Almost. It's logging you in with Google or something.
Okay. Let's see the pelvis first case.
Yeah, the first one should be an X-ray pelvis though. So click the second link if you click the top one, or click the second link then. Or they both should not be pelvises.
So I've got a
Yeah,
ring
so it's
now.
X-ray. Yeah, the second link is X-ray. Yeah, if you do the X-ray first, and then I'll load it. Okay, perfect. We're ready. So this
Okay.
is your first case. It's a patient who was found on the bottom of the stairs.
Okay, so I'm presented with frontal radiograph of the pelvis in a skeletally mature patient. I see there's multiple abnormalities on this, so I'm just going to work my way through. Firstly, there's evidence of previous surgery to the left hip joint. I suspect they've had a previous fracture on that side. I can't see any obvious complication associated with that surgical material. I'm just going to, given the history, just check my my lines for any obvious for any dislocation or fractures. So I'm just starting with the pelvic brim, which looks unremarkable. It's partly obscured by the what I think is the urinary bladder. Look at my ilioischial and iliopectineal lines. They are also continuous. I'm looking at the pubic symphysis, and on the right side it looks slightly obscured or indistinct, but that may be entirely unrelated. I can see there's some background vascular calcification. Now I'm just looking for any, the hip joints are both congruent as well. I'm looking for any fractures. I haven't identified any. So now I'm just looking at the bones more generally. I can see that there's generalized osteopenia, but I don't see any bone destruction or any masses. So now just looking at the surrounding structures and the soft tissues. There's some like particulate dense material around the pelvis, possibly feces. Patient may be in a diaper or something similar.
Can you show me where?
Can I tell you where?
Show me
Or
with your
show
mouse.
you? So I'm looking at all this.
Okay. So what do you think that
down
is? You said.
I think it's external to the patient. I think it's possibly feces, or maybe they've got like a stoma bag or something that's down there.
Okay.
It looks quite unusual to me. And then in the pelvic region, there's how do I describe it? Almost like a lentiform structure displaced to the left. I suspect this is actually the urinary bladder and it's filled with contrast, in which case I am a bit concerned because it looks indented and displaced to the left. A patient with a history of trauma, I would be concerned that this may represent a pelvic hematoma. So just putting this, and I can see the bowel loops superiorly, but they look unremarkable. Putting this all together, we've got a patient here who's experienced trauma. I can't see any definite fracture or dislocation, but I am concerned that there is pelvic abnormality, which is displacing the bladder to the left. I think in that instance, probably need some urgent cross-sectional imaging, and in this setting, I'll start with a CT of the abdomen and pelvis.
Okay, go ahead. It's your
Yeah.
other case that you clicked initially. I think it might be the first one. They might be in the wrong order, unfortunately. My bad.
This okay. So I've got cross-sectional imaging in the same patient. I can see there's
I think your screens are frozen. There you go.
oh, do you see it
It's just
now?
delayed. It's just delayed. Go ahead.
Okay. So I'm just going to scroll through the whole image set before I present my findings. I'm going to focus my search on the pelvis. Okay, so I think this does correlate well with the radiograph actually. So I can see there's a hyperdense structure in the right side of the pelvis. They've got a fairly collapsed, well, no, completely collapsed catheterized urinary bladder, which is displaced to the left. I'm assessing carefully and I'm looking specifically for any extraluminal contrast. I don't see any. There is a posterior to that lentiform hyperdense structure, but I think was this a female patient? Sorry.
You tell me.
I think it is a female patient, and I think that represents the uterus. There's some calcification within. I can't identify prostate. In any case, I don't think that's related to the presentation.
But I want to know
think,
now: is this a male or female patient?
I'm saying that's a female patient.
Okay.
So I do, my differential remains the same as on the radiograph. I think this represents a right-sided hematoma. I'm just going to check the bones carefully. I can see there's some pelvic fractures. So the right inferior, pubic extending to the right side of the pubic symphysis. Sorry, superior pubic ramus. One other consideration I have is whether this actually does represent urine within the pelvis. But given the fact that this appears to be a delayed study, I think you'd expect to see some extraluminal contrast in that case. So I would urgently inform the referring team. I think the patient does need review by urology in any case. The primary concern is this hematoma on the right side.
Okay, John, go to your next case.
Is it a CT head?
It's that scan.
Okay. Is there a history of this patient?
No, you tell me what's going on.
Okay, so I've got axial slices of a CT head. I'm just going to. Oh.
Actually, I think it'll be a bit hard. I'll give you a little bit of history. So it's a patient with headaches and blurred vision.
Is there a way I can reset the image? There we go.
Yeah, if you go to the reset all. There you go.
Headaches and blurred vision, was it?
Yeah, if you click scroll on the bar, it'll make you.
That's fine. Thank you. I'm just going to scroll through the entire image set. Okay, so there's an abnormality in the suprasellar region where I can see there's very low density with foci of hyperdensity within, possibly calcification. I'm just going to check on. Do we have this?
That's fine. Just keep it on the default setting, please.
Okay.
Reset again.
So I'm
all the
used
way
to this fact system.
That's all right.
Okay. The reason I was checking on that window was to see if this is gas or if it's fat density that we're seeing.
So what do you think?
So I think it's actually fat density because it wasn't fully black on the lung windows. In my normal practice, I would use Hounsfield units to assess it more clearly.
It's minus 125.
It's minus 125, did you say?
Yeah.
Okay. So I think that's typically I'd expect about minus 50 to 100 for fat density, but if it was gas, I think it'd be much lower than that. So I'm just going to check the remainder of the images. I'm looking at the brain parenchyma. I'm looking for
Don't
any
worry about this.
hemorrhage. No. So I'm going to focus attention on this lesion here. Fat density lesion in the brain, there's a couple of things that represent a lipoma, but this looks slightly atypical for a lipoma, especially with this high density within. One other thing we'd be concerned about is intracranial dermoid. I think that would fit given the what I believe is calcification and also its midline location. I'm checking carefully the remainder of the brain to check if I can see signal elsewhere, just to check if there's any evidence of rupture, because I'd be concerned about a resultant chemical meningitis, and I don't think there is. So I think that's our primary abnormality. I can't see any complications such as hydrocephalus or herniation. I think to confirm the diagnosis, I would recommend an MRI. And I'd expect
And how would that help?
I'd expect to see high T1 signal, which would suppress on fat sats imaging. I think that'd be enough to confirm.
Okay. Do you want to load your last case?
Is it abdomen and pelvis?
Yep, that's the one. So it's patient with abdominal pain.
Okay, so CT, abdomen and pelvis. I've got to slice this. Just going to scroll through the whole set. It's taking to load, unfortunately. Okay, just while I wait for the rest of the image to load, I'm just going to describe what I've seen so far. So I can see there's gross abnormality in the right lobe of the liver, where there's multiple low density lesions which are rim enhancing. Some of them, particularly, it could be described as peripheral nodular enhancement, but I don't think the other lesions fit that particular description. Looking at the hepatic parenchyma, I think it's generally unremarkable. There's some attenuation further to the left, but I think that's focal fatty infiltration. Portal vein and hepatic veins look unremarkable to me. Just looking at the remainder of the solid organs in the upper abdomen, spleen, kidneys look okay, although there's a bit of asymmetry and some pelvic dilatation. Pancreas looks unremarkable. Adrenals look unremarkable.
Okay, so wait, so do you think the kidneys are normal?
So I think the left side, I think there's some cortical scarring. I think there's some pelvic dilatation on the left, but I really doubt that this is related to the patient's presentation. There's normal enhancement. I can't see any perionephric fat stranding. I don't see any focal lesions or any adjacent collections. And the ureter on that side more distally, there's a bit of actual ureteric dilatation. So I'm just going to go all the way down. Okay. I'd like to retract the statements I made earlier, because I think there is some ureteric dilatation more distally, and it seems to be drawn into a pelvic mass, which appears to be contiguous with the patient's uterus. I'm just going to see if I can follow it all the way down to the left VUJ. Can't see it fully clearly, but I do think it goes its normal distally. But I think there's a degree of obstruction at this level. I'm just looking around this area for any other abnormalities. I think there's some fat stranding in the region, but I can't see any.
Do you wanna
What was that? Sorry.
do you wanna tie it all together? You've said everything.
Okay.
That's important.
Yeah. So I think these lesions in the liver, they're quite concerning for hepatic abscesses. Ideally, I'd correlate with the patient's inflammatory marker to confirm. I think in the context of this inflammatory change that I'm seeing further in the pelvis and the sided ureterohydronephrosis that we're seeing, although mild, I think this represents an inflammatory or infective process. Potentially the patient has PID, and that's what's causing this obstruction. And then we've seen concomitant infection in the right lobe of the liver as a result. I would inform the referring team. I would recommend cross-sectional MRI of that liver and a review by HPB and HPB gynae and urology teams for this patient.
Okay. What will the MR liver add?
I think if we see enhancement and we see central restriction in these lesions, it does make it more likely that these are abscesses. But I suppose if the clinical picture fits, it's not necessary.
Do you have any other differentials for them?
This could be a malignant process. We could see multiple cystic lesions in the right lobe of the liver. I think actually that's quite common for gynae malignancies. Otherwise, these could be entirely unrelated. We could be seeing like cystic lesion in the liver, either cystadenoma or hydatid, and then we've got unrelated pathology in the pelvis.
Yeah. So do you think could it be a hydatid?
It could be a hydatid. I didn't see a classic like water lily sign, which is what I'd expect to see, but yeah.
Okay. All right. I'll go for cases. Yeah, you did great. I just be careful you don't dig yourself in holes towards the end there. But otherwise you're doing fine. Cool. All right, we'll go over the cases. First case, yeah, it's this case exactly, the pelvic hematoma. The main thing here is it's contrast in the bladder, it's going over. You did say the right pubic was obscured. But yeah, it's not really obscured. It's coming to fracture, right? When you look on the CT, it's gone. So yeah, so really good. So they had a trauma. So the patient was found at the bottom of the stairs was the history. So the idea is they're obviously falling down the stairs, right? So yeah, fracture, hematoma. But they had a trauma scan beforehand, which is why there's contrast in the bladder. This is just the next X-ray, but I think it's a great X-ray because it shows this pelvic mass lesion pushing the contrast in the bladder over. So it's really nice to just know there's something there. So this is basically contrast in an adult incontinence pad. That's why it's given the speculative. Okay. So if you saw this in a pediatric patient, you think nappy straight away. But in an adult, same principle. It's an incontinence pad, and there's just these speckled bits of urine mixed with gas in the nappy. Well, adult diaper, whatever you want to call it. Incontinence pad is probably the most appropriate terminology. There's also a pelvic binder. And yeah, you said pelvic, it's just a DHS. You could just say DHS, it doesn't matter. It's all good. But otherwise, you go to here, and then yeah, just your diagnosis is there, pelvic hematoma. The thing that you said a lot when you get rid of it is I think. You don't think there is or there isn't. You don't need to, be a bit more confident. Rather than saying I think there is a fracture, or I think this, just say there is. This is in keeping with pelvic hematoma. There's no contrast catheterization on the single phase. But yeah, but you would be, it's big. If they, and then orthopedics need to be involved because if it's getting bigger and it's not containing, then they might actually, yeah, Mo's corrected myself. It's an IM nail, not a DHS. So, you can see I'm a GI radiologist, not an orthopedic. So 100%. Thank you, Mo. And Yeah, so that's it really. But really good job otherwise. The main thing here is comminuted fracture, pelvic hematoma, and nothing else to really add on that case. This
I
one,
got so
yeah, this one.
nervous.
Sorry.
Sorry, I got so nervous. I kept like stumbling my words and
I know you did really good. You're in a good place. I would have passed you for sure. Don't worry. But just be a bit slicker, more confident in the exam. That's all. Yeah, this one you got it straight away. You found it. I thought it was very tricky. I was gonna try to leave you to it, but then I thought it's a bit unfair. So then I said, there's fat content, there's calcification, um, and yeah, so they'll merge until proven otherwise. Whether you need to do an MR, I think Hanji has also mentioned, is probably not necessary. The only reason why you might in this patient is because they have blurred vision, so you might want to do an MR to just look at the optic chiasma, make sure it's not compressing any optic pathway. Otherwise, yeah, compared to previous imaging, this patient had it for ages. They don't really need an MR if it's just long-standing and not really causing them any issue. The other thing is sometimes these can rupture, so it would be good to just say I don't see any fat density in the ventricles or anywhere else, or in the in the subarachnoid spaces, just to show that it's not ruptured. Essentially, would have been nice touch because they can rupture.
oh,
But
I did say
otherwise,
that. Well, I
you
said I was
did
looking for it. I don't know if I said.
perfect. You cut off a little bit a few times, but that's fine. But yeah, just for everyone else, just remember they can rupture. But really good job. Otherwise, this case is a tricky one. You got there in the end. Um, so yeah, you've got these hepatic lesions. They're peripherally enhancing. I think at one point you said peripheral nodule enhancement. Be careful. The moment you say that,
Yeah,
that means hemangioma in my head.
yeah.
So just be careful when you say that. So yeah, peripherally enhancing lesions. They look like abscesses. Then the left kidney, yeah, there's this hydronephrosis. It is atrophic already, so we've got hydronephrosis in the atrophic kidney. But then you come here, you've got this tubovarian abscess, or this all this fat stranding around it. It's pelvic inflammatory disease with hepatic abscesses. You can get like this was it Fitzhugh-Curtis syndrome or whatever that is. That's just patients who have pelvic inflammatory disease with perihepatitis, and they get like this right upper quadrant pain because of that. It's just something to bear in mind, just to remember. But this is a bit different because it's actual abscesses. Yeah, so urology needs to be involved, obviously, because gynecology, urology, and yeah, the surgeons as well. So multidisciplinary approach to this patient, but gynae should take first priority because it's obviously this is all caused because of the pelvic inflammatory disease.
So it's
Cool.
not hydatid cyst.
No. So hydatitis, you get like the daughter cyst, right?
Yeah.
And you wouldn't get this pelvic. You could get pelvic cyst as well with hydatid, but you get these daughter cysts. So you get like a large cyst, and inside you get lots of smaller cysts inside, usually. And yeah, but no, it doesn't look like hydatid in this case. But okay to give it as a differential, but then dismiss it because of those reasons, really. Cool. All
Thank you.
right. No worries. Great job. All right, we can do one more, and then I think my brain's getting slower, and I'm starting to make silly mistakes too. All right. Hongi. How do you like to be called?
Hey, yep.
Hey,
On Jay.
Honjay. We've been emailing back and forth for a while now. It's nice to finally meet you.
Yeah.
So here are your free cases. All right, I'll put the timer on for you, and let's wait, share your screen first actually before I put the timer on.
Can't see any cases in the chat here.
Interesting. That's because I haven't clicked enter. There we go. Sorry about that.
Okay. Perfect. Got a few of these here. And then share. Not working?
Yeah, that is working. Yeah, all right, let me put the timer on. Just give me a second. So this is your first case. It's a patient who has abdominal pain, obviously.
Okay, no problem. So we've got a CT abdomen pelvis portovenous phase in a patient with abdominal pain. Just going to go through the full stack of images before presenting my findings. Okay, so you can see that there is an abnormal inflammatory process in the right iliac fossa. Just trying to trace the anatomy of this region. We've got the cecum, and then this here, I think, is the terminal ileum. So just trying to see where the appendix relates to all of this. There's quite a lot of fat stranding in this region. And then don't see any background diverticulosis of the large bowel in RAF. I'm trying to just locate the appendix, but finding that a little bit difficult. There is free fluid in the pelvis as well.
Can you find
And
the
then we've
appendix,
got,
please?
okay,
Pick
so
it
I
down.
think, no, I'm not entirely sure, but I feel like this is part of the appendix going down into the right inguinal region, possibly, with some, especially at this sort of level here. So could be dealing with an ambiend. But regardless, this epicenter of the inflammatory process is a little bit higher than that, more in the RAF. So terminal ileum at this level, and don't see any appendiculith. And then whether or not this is related to, yeah. So I think this process here is possibly, it's not convincingly off the appendix. I don't see like a blind ending tubular structure relating to that, but what I do see is that there is an adjacent sort of loop of distal ileum. So it could be that this is a sort of Meckel's diverticulitis, with like we're seeing the inflammatory stranding around it.
Okay, so what is
So,
Meckel's?
so it's essentially like diverticulum of the distal ileum, sort of about 2 feet from the terminal ileum, the row of twos, and that can get inflamed and perforate, or just form like a abscess, nasty sort of inflammatory process or collection.
Okay. Do you
Could be
see a Meckel's in this case?
It's hard to be sure. There's a lot of inflammatory action going on in this location here. Not convincingly. So beyond that, there is, I mean, I guess the other thing that this could be is we're sort of getting mostly fat density and a ring of sort of a ring sort of sign around this. So this could be an epiploic appendigitis, would be the other differential to consider here. So
Okay.
I would want to correlate
Yes.
with the patient's inflammatory markers. I'd, in my routine practice, review this in MPR to try and definitively see where the appendix is. Not convincingly seeing that at the moment. Able to
Okay.
identify terminal ileum.
You can MPR it, C for coronal, S for sagittal.
Yeah, so I think I'm leaning more towards maybe like an epiploic appendigitis here,
Okay.
getting a
What's
bit
the
of a fat halo appearance.
what's the pathophysiology of a epiploic appendigitis?
It's a fat necrosis involving the epiploic appendages.
Okay. And how does that usually present? What side and what size?
I mean, could be variable. Like, this size is not beyond the realms of possibility for epiploic appendigitis, but I suppose they're typically maybe more on the antemesenteric border.
Okay. What are you going to do next?
So would want to correlate with inflammatory markers, would want the surgical team to review the patient. I think there's definitely an inflammatory process going on here, which under non-exam conditions spent longer in trying to locate the appendix to be sure that we're not dealing with acute appendicitis. But I'm not getting the impression that this is, because if it was, I think it would be a bit more obvious, and we might be seeing, like, with that amount of inflammation, it might be more of a solid phlegmon sort of process should that have been a ruptured appendicitis. So I'm thinking it's more likely to be one of the alternative differentials. But regardless, I would, if there is doubt in my routine practice, I would describe the inflammatory process, correlate clinically, and they could always go for either watch and wait or a diagnostic laparoscopy to be definitive about this.
Okay, do you want to load your next case, please?
Yeah.
So it's a patient with face swelling.
Okay, so we've got a non-con CD brain in a patient with some facial swelling. Just going to take a moment to scroll through the full stack of images. It's a little bit slow, apologies. So far, I can see that there is subcutaneous soft tissue swelling involving the right side of the face and periorbital region. Scrolling very slowly for me, sorry. 1 second. Okay, so it looks like this is actually a post-con study, apologies. We can see enhancement of circulus vessels. So essentially what we have is a lot of periorbital swelling. I presume that this is probably going to look a little bit like a periorbital or orbital cellulitis, is probably part of their differential clinically. I can see that there doesn't seem to be any intraconal involvement or retroorbital involvement. The main abnormality that is maybe a little bit more concerning is that there seems to be swelling of the right superior orbital region at this location.
What is that?
It's I think it's maybe close to between the lateral rectus and superior rectus
Yeah. What
orbital
is that
muscles.
structure?
Well, like lacrimal gland,
Yeah,
potentially.
it's a normal.
But
It's
it
a
looks
normal. It's a normal lacrimal gland.
fine. Okay, fine. So then looking just to see if there's any intracranial extension, any retroorbital extension of this process, or any sort of collections. I would want to look at it in 3D MPR, especially the coronal reformat, just to see as well, and then seeing if there is any asymmetry to the retroorbital anatomy in terms of optic nerve, and as well as like the retroorbital vein and the vessels.
Okay. So
on-
just on clinical, they've got swelling of the medial canthus.
Okay. So I can see that there seems to be a low density structure at this location with peripheral enhancement. So this would make me concerned that there is a focal collection or abscess developing here. I'd want to look at the bone window to see if there is involvement through the lamina propria at this location, or in this location of the bony structures.
Bones are fine.
Okay, fine. So in summary, whilst there's no intraconal involvement of this infection, there is involvement of the extrapyramidal region medially. with an impression of a small collection which is enhancing. So this patient would require urgent referral to ophthalmology and consideration of drainage. I would also look at the rest of the brain just to make sure there's no intracranial component or any extra axial collections.
Do you know where this is located, the collection, anatomically?
Where what, sorry?
Where is the collection located anatomically?
Anatomically, looks to be I think that's it's I was gonna say it's quite close to like the tear duct drainage sort of pathways there, but
Okay.
I'm not.
Yeah. I agree.
So then I guess you want to make sure that there's no sort of extension into the rest of the nasopharynx as well with this.
Can you load your next case, please?
Yeah.
So it should be a case.
Sorry, this one here.
Yeah, case 20. So this is a patient who's got abdominal pain, query, obstructing stone.
Sure. Okay. So got non-con CT abdomen pelvis here. Looking for stone disease. So this is done as essentially a KUB study. Just going to go through the full stack of images. Okay, so looking then to following the tract of the renal collecting system, I can see already that there is a bit of a hydronephrosis, moderate degree on the left-hand side. Right side seems to also have some pelvic ileocecal dilatation with cortical thinning of the kidney off the right-hand side. You can see that there's a couple of densities on this non-con study, which looks to be intrarenal non-obstructing stones on the right. Left-hand side, don't see any in the intrarenal part. I would then follow the course of the ureters just to see if we can identify an obstructing stone.
Go ahead.
Trying to see where bladder's not distended. So getting the impression that the patient doesn't have a bladder, and I think we have a maybe like an ileal conduit on the go here. It's quite hard to tell without any contrast, but there seems to be no bladder, and then I can see that there is looks to be a normal sort of continuation of large bowel from the GI side of things, but there seems to be a stoma going into the RAF. I presume that's a urostomy and ileal conduit. So following this tubular structure back. Yeah, so this is in keeping. I can track the ureters going into the ileal conduit here. So following this in and then going across. Trying to look to see if there's a focal level of obstruction. I think the ileal conduit itself is maybe a little bit more distended than you'd expect. Usually they're quite collapsed, and there seems to be bilateral hydro. So I feel like this is then maybe quite a distal sort of pathology. So I wonder if the obstructing stone is actually at the skin level at this location here, and maybe that is causing a blockage and then bilateral hydronephrosis. So I would want to correlate this with, patient's prior surgical history or any previous CTs. But that would be my impression based on this here. So patient would require urgent urology review, and considering this level of obstruction, should my interpretation be correct, it's quite a low level, superficial level of obstruction. So I don't think an urgent nephrostomy is necessarily required. They can try and see if they can remove this from the urology team clinically rather than involving IR, but that's always an option should the patient require it.
Yeah. So how do you think How do you think they could remove it?
So for that level, it's very, very much superficial. They might be able to sort of see what it looks like, what with a urostomy stoma bag removed, to see if there's anything obvious at the skin level. So if they can't remove it, I mean, they could potentially do like a cystoscope into that area, but I think that probably from the looks of these images, that's the pathway into it is going to be blocked. So beyond just manually trying to extract the stone, I can't think of
Okay,
any other
perfect.
instrumentation that they would use here.
Perfect. That's fine. That's what I wanted to hear. All right, cool. Good job. Yeah, I didn't want you to say manual. Just try to take it out. That's what I was getting at, but you did it. Good job.
Yeah.
Awesome. I'll go with the case. You did really well. So really good job. Let's go over the cases. So first case. Okay, so this case, I wanted just to be a bit slicker, and I'll go over it a little bit more with you. So I'm assuming you can see my screen. So this is a case. Yeah, like you said, right leg fossa. There's this centrally fatty lesion, and peripherally there's all this fat shredding. So it's almost like an encapsulated fat with fat shredding around. Sure, there's reactive changes a little bit on the cecum, but the main thing here is the cecum looks okay, the terminal island looks okay, and then also the appendix, which is over here. So you see the structure here,
Mm.
and then disappears, and then attaches to the cecal
Right.
pole. So that's your appendix. So appendix is normal, cecum's normal, terminal ileum's normal. So everything's normal, but there's still this fatty structure with fat stranding around. So this is what a mental infarct looks like. So it's kind of the same spectrum as a epiploic appendigitis, they're all fat ischemia essentially. But the difference is epiploic appendigitis, you have these appendages which are fat nubbins that are on the colon. When they twist, you get epiploic appendigitis. They're usually smaller, cigar-shaped. So this is a bit too big for that. But whereas a mental infarct, you've got twisting of the omentum, then the vessels become, the compromised flow, and then you get this almost like a fat necrosis type of picture. Both of them treated conservatively. They usually don't do anything. They sit them, wait, and then they usually get better. So yeah, just be aware. Same spectrum. Right-sided, usually, again, it's not always the case, but traditionally, right-sided usually mental infarcts are usually larger. Left-sided usually epiploic appendigitis and usually smaller. Okay. Next case. Yeah, this is tricky. It's a tricky case. The main thing about this case is knowing your anatomy a bit better. It's more of like anatomy, lacrimal slash nasal lacrimal duct anatomy tester case. So first of all, you've got a CT sinuses slash orbits in the venous phase. You've got all this swelling, like you said, periorbital, no intracoronal extension, no intracranial extension. So everything was good. It is, oh, it's a magnifying glass. Just want to zoom. It is a bit tricky to see the thing, but I gave you a prompt. So it said medial canthus, then you got it straight away. You said there's a collection here. So this is a collection in the nasal lacrimal sac. So you've got your your lacrimal gland up here, which sits laterally, superlaterally, which you found it initially. So your tears are produced here. They go into the eye, lubricate the eye, and then they drain medially in your lacrimal sac. Whereas here, you've got a collection here, so it's blocked up, and there's collection, and then that goes into the nasal lacrimal duct, which you can see extending down here. So just to refresh your anatomy. So this is what we call dacryocystitis. Dacry is just a fancy Greek term, and dacryocystitis is the Greek terminology for fancy lacrimal sac collection or inflammation, I guess is the proper term, if you say itis. So yeah. It's kind of one of those, if you know it or you don't in a way. But just remember that dacryocystitis. Just keep that in your memory for the future. And in this case, you did it really well. It's a very, very tricky case, I think, but you found it straight away. Well, not taking time. You found it in the appropriate time. You realize the bladder's gone. You realize that there's a little conduit, and then you found the stone at the end. So really, really good job. And yeah, I remember I saw this case, and I called the clinician, like, can you just get a tweezer and just take it out? Just take it out. It'll be all right. So yeah, I think you could probably just manually see that and just take it out. But yeah, really, really good job on those cases. So yeah, I hope that was useful, guys. I hope you found it useful. I hope even the ones that went viral took something from this too. and there were some good cases that you got to see. And just remember that at the end of the day, the whole point of this exam is to just show you're ready to be a consultant and you're ready to go. Just like our friend Tajish, if I said that correctly, I don't remember exactly, who absolutely smashed it. That's the ideal, what they're looking for, right? That's your top end. You don't have to absolutely smash it, but you just have to do the best you can do and try to get as many points as you can, as much as you can, and then and I'm sure you guys will do fine. So yeah, thanks for joining. I hope you found Rad Bytes useful on the platform, and I really do appreciate the feedback you guys have given. We do take it on board, and we really do try to make changes and try to improve the platform as we can. A lot of you have suggested about adding some long cases, and that's something we're working on in the pipeline too. So hopefully that'll be up soon. But hopefully you guys won't need to care about that because you'll all be done with your exams anyway. James said, will there be another session? I usually do a session per exam, so there won't be another session for March, but I'll do one for June. So I try to do one for each, basically. But yeah, cool. Well, thanks, guys. Thanks for joining. Good luck, and if you need anything, message me, and I'll get back to you guys too. And wishing you all the best. And I'll hang around for a few more minutes. If anyone wants to ask me cases, questions about the cases or anything in general, I'll hang for a few more minutes. But yeah.
Just a quick one. I'm really sorry. I missed the last case. What was it?
The last case was the ileo. So it was a patient with an ileoconduit, and so they had a previous cystectomy. There's no bladder. They had an ileoconduit, and then there's a